A tibia fracture can look like the emergency, but sometimes the real threat is pressure building inside the leg. Acute compartment syndrome is urgent because muscle and nerve live inside closed rooms of fascia. When swelling or bleeding rises inside that closed space, the room does not stretch enough. The pressure starts to squeeze small vessels, so oxygen delivery falls exactly when injured tissue needs it most. Think of the lower leg as compartments, not one soft bag. Each compartment carries muscle, nerves, and vessels wrapped in tough fascia. The anterior compartment is a common place to worry, but the same principle can apply in the leg, forearm, hand, foot, thigh, or buttock. The key mechanical idea is simple. Volume goes up, the envelope stays tight, pressure rises. A fracture is the classic trigger, especially high-energy tibial trauma. But crush injury, vascular injury, reperfusion, bleeding, burns, tight dressings, and severe muscle contusion can build the same trap. The skin may not look dramatic at first. The danger is inside the fascial compartment. The early clinical clue is pain out of proportion. Pain increases when the muscle inside the compartment is passively stretched. Tingling, burning, or altered sensation can follow as nerves become ischemic. A tense, full compartment matters. Pale skin, paralysis, and absent pulses are late signs, not reassuring targets to wait for. Diagnosis starts with repeated examination and a high index of suspicion. Pain medicine does not erase the duty to reassess. Casts, splints, and dressings should not hide a changing limb. When the examination is unreliable, compartment pressure measurement can help. Numbers are interpreted with the whole picture: compartment pressure, systemic blood pressure, mechanism, and progression. At the tissue level, the problem is perfusion. As compartment pressure approaches the pressure driving blood through capillaries, flow becomes less reliable. Muscle and nerve tolerate ischemia poorly. Hours matter. The longer pressure remains unchecked, the greater the risk of necrosis, contracture, infection, kidney injury from muscle breakdown, or limb loss. Initial steps remove external pressure, split tight casts, loosen circumferential dressings, keep the limb at heart level, and support blood pressure. But true acute compartment syndrome is a surgical emergency. Fasciotomy opens the fascia so swollen tissue has room, restoring the pressure gradient that lets blood flow. The wound may not close immediately. It may need delayed closure or grafting after swelling settles. The practical pathway has 4 linked moves. Recognize the risk mechanism. Re-examine the limb repeatedly. Measure pressure when the exam is unclear. Escalate early for decompression when the diagnosis is made. The lesson is not to memorize a number, it is to understand the closed space, the rising pressure, and the clock.